Thank the chief instructor for allowing me to participate in this IC. What I'm here to talk about is basically the dilemmas faced by a beginner while performing these complicated surgeries. Now, we do get these cases even as a beginner in our practice. So usually what I ask a lot of my friends that what do you do, so that I get a non-biased answer regarding the modus operandi of a beginner. So usually the cases are either referred to a senior surgeon, or they land up as a SICS or an ICCE. But why is this dilemma? I asked my friends and I came up with three basic common answers. Firstly, lack of experience. We are not experienced enough to do these cases. We are not confident enough to do these cases. I don't know why. And third was the most irritating answer I got was, why should I do it when I can get a senior to do it for free? So possible complications any surgeon might encounter, may be a beginner, may be a experienced surgeon, is either ICC, iris injury, posterior dislocation, prolonged surgery, or uveitis or corneal damage. Now this can happen to anybody, not just a beginner. It can happen to a experienced surgeon also. Initially, I would advise not to go in for very difficult cases like thoroughly uncooperative patient, deep set eyes, large degrees of subluxation. You can go in for mild degrees of subluxation for your first 3 or 4 cases, and then you can go in for more difficult cases as shown by the previous speakers. So I would like to show you a small video here. This is a case of, a traumatic cataract. This whole area is basically in front of the iris, and this part temporally, I'm sitting temporally, is basically behind the iris. In these cases, usually I don't prefer to use blue. If I have even a little amount of visualization, I go in with a high molecular weight viscoelastic, create space. Blue goes into the vitreous, I lose the glow. If I lose the glow, the surgery becomes very difficult. A technique was taught to me by one of my seniors, Arnab Biswas, that you can, put blue inside the bag after the rexis to identify the margins. That's a very useful technique and it's quite effective. So, in this case, as you can see, as you will see, the bag is so mobile that even a nick with a sharp cystotome is so difficult. You can see the whole movement of the bag. Just a small nick. I just wanted to make a small nick so that I can go in with the forceps and then complete the rexis. So usually in these cases what I do follow is I make a small nick so as to get a small grip by the forceps, because puncturing the capsule in these cases with the forceps is very difficult. And then I support the bag or the lens with a second instrument and put counter traction while complete the rexis with the forceps. This stabilizes the bag, gives me a good grip on the capsule and doesn't allow the capsule to run out and the bag to be mobile while doing the rexis. At all stages, it's imperative to maintain a counter traction in the opposite direction to the rexis. At least that is what I feel very comfortable with. After completing the rexis, before doing hydro, I usually go in for CTR implantation. I first dial the leading end in and always support the part where the CTR is going inside the bag with a second instrument like here and gently dial the CTR inside. And then just before inserting the CTR inside the bag here, I always maintain a second hold here, because if I lose the CTR inside the sulcus in these traumatic cases, it's very difficult to retrieve. Next stage, I put in the hooks. In this case, I used capsular hooks. I'm not very comfortable with these hooks because they are very large. They occupy a lot of space. But here, the rexis here was very close to the equator. So I didn't know whether the iris hooks would, damage the equator or puncture the equator. So in these cases, this area of subluxation, I used iris capsular hooks, and these areas I used iris hooks with which I am much more comfortable, and they are less space occupying, they are easier to put in. After you put in the 4 hooks, stabilize the bag well, apply equal traction in all areas, And believe me, at this stage with the CTR in and with the hooks in, it's like doing normal phacoemulsification. You just have to reduce the parameters. Normally I work with 400. You can see the parameter. I've reduced it down to 300, 310. I've brought down the aspiration to 28. And you can see you can complete the surgery here successfully by following these basic 3 simple steps in cases of any degree of subluxation. You assess the movement of the lens at any stage of surgery and then proceed with additional steps. First put in the hooks. If you think hooks are not good enough, then you put in the CTR. If you think CTR is not good enough, then you put in the segments. And another thing I wanted to show is, let's skip this video. Yeah, this video. This was a case of a very small pupil, a 2 millimeter pupil. Even after stretch, it didn't expand. I put in the hooks. I had put in the blue before putting the hooks, and you can see here that there's absolutely no glow. That's because the whole blue has gone inside the vitreous. This is what I want to avoid. You can't make out anything. Believe me, the microscope I have been given by my seniors is one of the best. And with this is the poor glow I have. But I can make out, if you can here, some anteriorly inserted zonules here, 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 wherever the iris has been expanded. So this basically was a case of small pupil with spherophakia. Now since I didn't have the glow, I was not very comfortable in putting in a CTR because I didn't know where the CTR would land up. It might go inside the vitreous, which I wouldn't be able to remove even in the same setting. So in this case, thankfully I could complete the surgery. I wanted to show you this video because before inserting the lens in any compromised stable bag, what I do is I use a second instrument to again put a counter traction on the edge of the rhexis where the bag is getting in, and then slowly dial in the bag. This puts a lot of less stress on that area so that you don't dialyze the rest of the bag. I find this technique very effective in cases of subluxated small areas of subluxation. Support the area of the rhexis from where you're trying to insert the lens. It's very easy. And then with the second instrument you can dial the lens in, and that would not put that much stress on the bag. Now, to conclude, like I started in my initial days, I had chief instructor Dr. Ajay Paul and Dr. Arnab Biswas beside me. One person told me, you do whatever you like, I'll manage the rest. And the other said, you do whatever you like and you do the rest. So basically I ended up doing all sorts of complications, but then the advantage was I knew at what stage what complications occur. And then I could stop there and call the senior. Get a person to stand beside you. But what I would like to emphasize is do your cases. Please don't give them to others, even if they do it for free. Get the complications done. All these instructors here are because they have had all the complications. They know it's not how good you can do a normal case, it's how well you can manage a disaster. So unless you have a disaster, you can't manage. Get a senior who'll stand beside you. He'll help you to do your cases. He'll help you, he'll just complete the difficult part, then again get back into the surgery. That's how we learnt. Steve Jobs said that no guts, no glory. You have to do difficult cases, otherwise you'll just be another ophthalmologist in the crowd. If you want to be on stage, you have to do these cases. You'll have 50 complications. Believe me, initially most of the instructors in this IC got on stage because of the complications and not of the management. So this is the best part. First time I presented a video in any international forum was because of a disaster which has happened and not because of a successful management. So I would end my session by saying, by quoting Roosevelt, I believe that anyone can conquer fear by doing things he fears to do. Repeat them over and over again till you get a series of successful experiences. Do 3, 4, 5 cases of subluxated IOLs. You'll have disasters. Believe me, in the first 3 cases. The first case will be okay. The second case will be as bad as you can imagine, except DOT you'll have everything. But then you'll start getting confidence. But don't start off with very difficult cases. Don't do surgeries in a case of 270 degrees subluxation, iris injury, and that is not a very good case to start with. Start off with a mild degree of subluxation. Do it yourself. At any stage you have any complications, ask your senior to assist you. Thank you.